going to be introducing a whole series of speakers over this period. We're going to be going around the globe talking to leaders, thought leaders in the different regions, and we're going to be hearing a little bit of their experience and what's happening there as well. I'm quite excited about this. We do have technical challenges, as always, when we're coming into these series. We're hopefully going to be able to share some thoughts with Dr. Cheung when we meet with him shortly. We are trying to get the slides available to see as well, but we will proceed no matter what. So thank you very much for that. So what we're going to do is do a short introduction to Dr. Cheung. We're then going to hear from him. We're going to do a discussion, an opportunity to ask questions from ourselves. We're interested in asking questions, but also from you, the attendees as well. We're going to do a live poll in the middle as well to get some of your thoughts on where we're going. And so we'd like you to use the question and answer panel if you have questions to ask. I'm sure this is going to be very insightful, and I hope that you're going to gain from this presentation. So a quick introduction then to Dr. Cheung, who is Head of Information Technology at Health Informatics and Chief Informatics Officer at Hong Kong Hospital Authority. Very exciting place, obviously, to work, but also has been instrumental for a very long time in ensuring that healthcare records have been built around Hong Kong so that they have a huge history and knowledge of the patients within their authority as well. It's a massive job that he's undertaken from that greenfield time and moving forward. Currently work focusing on taking the hospital authority clinical management system on the generational leap. And obviously we've seen some challenges in this first part of this year, which we'll hear a little bit more about as well. And Dr. Cheung is joining us today and in his private capacity, in his thought leadership role, and helping us to see a view of the wider world. So I'd like to hand over to Dr. Cheung. I'm sorry if we haven't been able to get the presentation on screen at this stage, but perhaps you could give us some of your thoughts as we go forward.
So just a quick, I'm working in Hong Kong, as you can see behind me there. I work for the Hospital Authority, which is the public healthcare provider in Hong Kong, and we are by far the largest provider. We have 43 hospitals, over 100 clinics, a lot of staff, a lot of beds, and a lot of activity. And so we run the whole healthcare system as one entity. And what we've we actually were only established in 1990, and back in those days it was a very IT-wise, it was a greenfield. So we sort of decided that we would use IT would be a key strategy moving forward. So you can see here that we've been building these systems in-house since the early 90s. Basically, everything in the clinical realm, all of our clinical IT has been developed by our own team. And we've gone through, it's been 25 years with the main system, which is called CMS, several generations of that, and we've built all sorts of modules, and it's basically a complete comprehensive system now, one single electronic patient record across all, well, it's more than 7 million patients in our record system, and their care is integrated across the whole of Hong Kong. We've also taken a lot of that technology and put it out into the wider Hong Kong health ecosystem, helping the government build the EHR sharing system, which allows public and private providers to to access a patient record if a patient should choose to do that. And the last one there is something called HA Go, which is our unified patient app, only released late last year, so we're early on that, but it's already proven to be a lot of value. So basically what we've been basically running the whole of the clinical service in HA on the CMS. And you see some numbers there. I mean, it's a very large system, huge volumes, billions of data points, and it's running at a very high level all the time because healthcare never stops. Next slide, please. So this has been essentially nearly a 30-year project for me. And when you operate a 30-year project, you don't do that by Gantt charts and that sort of thing. You sort of have to have underlying principles and approaches. So what we've always wanted to focus on is what really matters in healthcare. And if you look at this slide here, these have been the three pillars that we started with, which is one is the electronic patient record. So building it in a very standardized, structured, comprehensive way that's always accessible when it's needed by all caregivers to a patient. Secondly is very much we wanted to support the process of care. So it has to be enhancing to the workflow. It can't be an extra burden to our clinicians. And it needs to help them by helping them target the clinical effort. And lastly, very focused on improving quality and safety. So things like clinical decision support, a lot of measures, a lot of monitoring going on to make sure that everything's improving all the time. But then that's sort of how we undertook this whole endeavor. But then, if you go to the next slide, since then we've added a fourth pillar, which is, and this is in the last few years, very much more focused on engaging patients in their own care, looking towards new models of service delivery, not just confined to the hospital and clinic anymore, and very much to make data an actionable part of the whole system. So that's sort of where we've been taking it. Now this has sort of been, and we're sort of progressing along that red axis, even whilst we still improve the rest of it. And then next slide, please. Then we came to COVID. Now, Hong Kong is actually, oh, sorry, can you go back one? So this picture actually is the epidemiological curve for Hong Kong. And you can see we've pretty much flattened the curve. And so since sort of April, the slope's been very mild. And a lot of that's mostly imported cases with very sporadic local cases. So we're doing well there. Now, of course, a lot of that must be attributed to heroic healthcare efforts, to good public policy, and also to the general population, adhering to social distancing and mask wearing rules and all that stuff very well. And you can probably understand that because of the SARS experience we had in 2003, people sort of understand this is how you need to deal with this current situation. So next slide, please. So that very much when COVID hit, we realized quickly we knew we had to respond digitally. And part of what we've been doing in all the last 25 years was building up platforms. We've been building all these platforms for digital health, data sharing, operationalizing health on a digital platform. And so we were able to quickly leverage those platforms and rapidly deliver a lot of new initiatives in response to the healthcare needs of COVID. So if you go to the next slide. So on the bottom left there, you see timely, detailed case reporting. So what that is that we'd already, we actually done this starting from SARS, is where all infectious diseases, reportable diseases, we have a way that all the clinicians know that this is how we report them. It's highly structured, very timely, because it's being done at point of care, and that data rolls up into the hospital management and into the Department of Health for public health management as well. So that's like having very good awareness of all the cases with a lot of detail about each of those, and the right people get to see it. The red box at the left is something we did early on as well. When this COVID, certainly the travel is a big problem with imported cases, and we were able to communicate with the immigration department and get a update on any patients who come in. Did they travel recently? Now you probably understand, if with quarantine and so forth, people may not be so forthcoming about their travel, but with this flag, we definitely know if they've come in from somewhere else, so that the clinicians can take the appropriate precautions. And lastly, we have this dashboard here is so again, we've built up these dashboards over the last few years, and this one we sort of enhanced just to deal with the isolation beds and the specific situation of COVID. We're able to upgrade that very quickly to give the right information for our overall pandemic management. The next slide, this one is dealing with various care delivery initiatives we had. So let's have a look. Let's start from the bottom right there with timely test results. So testing is a big part of it, as you all know. And we were able to, again, use our existing test ordering and result reporting mechanisms and to extend that out to even where we're doing a lot of testing out in other areas, to be able to collect that is as if they were, in the hospital itself, and make that data available where it's needed. Secondly, on the bottom left there, we've got a caption called new sites. So again, you may have seen this in your own country, where the new facilities had to be suddenly set up to deal with the added demands of COVID. And we did this in one of our large exhibition center, and we were able to set up a site where, at least from the IT point of view, it was a first-class citizen, along with any of our existing hospitals, because we're able to deploy our systems out there very quickly and operate with full support. And the one in the middle there is, we call it telecare, just as a slightly broader word than telemedicine. So we use the word telecare. But this is not something amazingly new, but we did use this. This was an opportunity for us to get it off the ground, because we'd always had the technology, but again, there was a lot of other barriers to this sort of a service model, and now it's become much more mainstream, and we've been supporting that. I'll talk a little bit more about that in the end. Thirdly, we've got a few initiatives about engaging the patients themselves, and again, with COVID, patients are reluctant to come to the hospital, and there's all sorts of changes to do with that. So top left, we've got appointment management. Now this was happening. We've got that in our HA Go, which is the single app that I mentioned earlier, and people can see their own appointments and manage their appointments there. On the bottom left, we have a new part of HA Go called information prescription, where clinicians are able to prescribe information to patients. So the patient will receive personalized information to them. So this is very new for us. We also have another approach, which is called app prescription, where they can prescribe an actual module, a clinical module to the patient within HA Go if the patient needs it. So we're sort of integrating the clinical system that the doctor uses with the app that the patient has in their hand. On the top right there is televisit, and with COVID, family can't come into the hospital, so we've been enabling a lot of basically consumer grade devices that they can speak to their loved ones over the tele means, rather than coming into the wards. So that's just some of the stuff we did. And again, this was done with very little fuss, because we already had a lot of the basics in place. And a lot of it was perhaps an acceleration of things we'd already started to do. So some of that timing was a little bit lucky. But now I'm going to move on in this last section to talk about some of the new stuff that we're doing. And we've all heard the phrase the new normal. I think it's a very good term to describe what we're trying to achieve now. Now, even before COVID had struck, we'd already been talking a lot about the new things we want to do, bringing in an age of innovation to our healthcare, because it's clear that the pressures of healthcare, even before COVID, were extreme. Increasing demand, not enough healthcare workers, rising costs, all that sort of stuff. So we had to look at new ways of doing it, and part of that was for us to try and innovate and see how we could take it to the next level. So if you go to the next slide. So basically what I'm going to cover is just four sort of major areas. So the first one is the smart hospital. So this is it's a bit of a catchphrase, smart hospital, but to us it's sort of a mindset shift where we've always had the clinical systems we've tried to put a lot of smarts in, but we're talking now about the experience of the patient, the automation within the hospital, sort of reducing so there's still a lot of manual processes and queues and so forth in the hospital that the patients have to deal with, and we're trying to cut that all out with more modern approaches, self-service terminals, using the app a lot more, that sort of thing. So and then another part of the smart hospital is the way that new initiatives get deployed through the hospital. We're trying to package up our tech in a way that's much more amenable to people just taking it and using it, just like the consumer products. So that's something we're looking at, and that's a bit of a mindset change. On the right there, I've got a thing called ambient clinical intelligence, and so we've already got a lot of decision support in place. But what I'm really looking at now is building a fabric of intelligence throughout the system where it's very context aware, that there's rules firing all the time, AI models operating. and advising the clinicians, not taking action itself. In general, we're not talking about AIs doing stuff. We're talking about AIs advising people, and to do so in a very, again, workflow friendly way. So we have to spend a lot of time thinking about how the advice comes up, when does it get raised up, and who receives that advice, so that it's useful to the clinicians and helpful in their day-to-day work. Thirdly, HA Go on the bottom left there. Like I said, we had a lot of apps in the old days, and then it was becoming too much, and patients would have a hard time dealing with it and everything. So we decided to embark upon a single app strategy where we build it's really an app framework, and where we can plug in modules, and some of them are general, like appointments management or medications. You can just look at your own stuff there. But then we're building up more specific modules, clinical modules, like which we can prescribe to the patient. So we've already started with a rehabilitation module. So our therapists can prescribe that module to people, to patients to take home and do their exercises with the app, giving them advice on that. And we're going to move forward with that. And like I said, we're trying to close the loop between the hospital and clinic back to the person's home. And then when they come back to see that for their follow-up, that data is fed back in, and the doctors can see it next time as well. So that's the idea of the app. And just on the bottom right there, the very small several clouds there. So we're talking about here the digital health ecosystem. So it's a cloud of clouds, as they might say. And where we have the big one on the left is the HA cloud, with a lot of stuff happening in there with all our health records and stuff. We have the EHR cloud, which is the top right, which is the government cloud, where we're communicating with both the public and private sector and sharing the data out to the providers and the patients, with a lot of controls on privacy there. And the bottom one is the public cloud, where the public apps will be there. And HA Go is also there, but we also want to work with the app ecosystem and the innovation ecosystem, sort of more in that space. So just I promised to keep the presentation part short. So, and I do realize it's a little bit in the high level. Oh, let me just close with this one slide though, is that just to summarize, I think summarize 30 years of work in one slide here. So I think that for me, it's always been about focusing on healthcare delivery. And so one way to put it is that we do things for healthcare, we don't do things for administration. If you want stuff for administration, it has to come out of the healthcare. So that's sort of like been our mantra for decades. Engagement and alignment, certainly a key part of it's been engaging the clinicians and the other stakeholders, and engaging the patients now much more, aligning what we're doing with what the rest of the organization needs and what our clinicians need. And that's happening at the corporate level, at the hospital level. And then, like I've already mentioned, this platforms and ecosystems is not about building individual systems. It's about building whole ecosystems and platforms which can support a whole variety of things, and you get leverage out of that. And lastly, digital health capacity. I mean, we've had to build quite a large team of expertise, both in the IT side and on the informatics side, but just as importantly, amongst our clinician population and now increasingly amongst the management population, that they also understand what the digital health can do for them and how they can inform the design of the systems moving forward. And as I mentioned, patients increasingly will become part of that as well. So that is my presentation, and over to you, Tim.
Thank you very much, Professor Cheung. That was absolutely fascinating. And I think there are many attendees who are here today who will be quite envious of 30 years of data already being generated and held within the Hong Kong Health Authority, and in that starting point. Can I just remind everybody who is attending that you can put your questions in the question and answer blob. So if you put those in now, we can start answering some of those. But I've got one to start with. As I was saying, in terms of that volume of data, the envy really of many countries is where you start with that. And how you get there is not through a Gantt chart and a project management, because it's years and years of hard work. But what do you think was the major benefit in this crisis of that large quantity of data? What did it give you significantly?
Well, it did enable, well, I mean, because we'd been uh, driving the concept of, data-driven management and so forth, but people were able to, like, they would go to the data to ask questions. And now we'd already done, so you saw the dashboard, for instance, we'd already been trying to put it together in ways that would inform management anyway. So we're doing a lot of that work. But then to quickly be able to extract any new stuff that we hadn't been already doing, or to add some new visualizations, for instance, that was the sort of thing we could do. So we had the data, we had the experience, and we were quickly able to put a lot of new things together for people. And I think, but a lot of part of it is having an existing mindset where people would already be asking the right questions is something that I think is the wider cultural benefit.
Thank you. We do have some questions coming in. I've got a couple more that I just want to challenge you on first. In terms of the AI, I'm sorry, I forgot the words that you used in terms of those new AI platforms you're starting to develop. Can you just explain to me a little bit the value again of that large data set in driving AI and what you're starting to develop there?
So yeah, the word is starting, and now we are early on this, so we have a lot to learn. But I mean, if I may share my conceptual view of this, is that first of all, the modern sort of machine learning techniques, they basically rely on you having lots of data. Without lots of data, you just can't do it, right? So we have the data now. That of course you have to have good data, and you have to understand it well enough to train up the AIs that you need. So having the data there in the first place, but then for us, actually the models themselves, yes, certainly that's important. But for me, it's more about how those models can actually improve the process of care, how they can fit into the workflow of our users, and how we can minimize any potential problems caused by the AI itself. So to be very aware that AIs are, I mean, they can be a double-edged sword. I mean, all IT can be a double-edged sword. So be very aware of the possible downsides and not to sort of blindly charge in with a very hopeful, optimistic attitude, but to be much more realistic and measured in how we do it. So we're still moving quite slowly now to ensure that the approach we're taking is safe. The safety to us, I think, might be the most important concept. But basically, the idea is that if the AI, because it's very cheap to run AIs nowadays, right? They just sit there and they can work for you for free for, and they never have to rest. And so you can just have an army of these guys essentially informing different parts of your care process. Now, the key thing for me now is it's informing. They're only advising, and the level of advice can vary depending on what you're doing. But you can choose things that are low impact, but hopefully of some benefit. But because they're essentially free to operate, the impact doesn't have to be huge. It's still a benefit.
Thank you. I'm just jumping to one of the questions from Michael De Silva. I think it's how do you set up a data lake and data warehouse, an ETL, and some of the pain points, of course, because this is closely related to quality of data and quantity of data.
Okay, well, so I hope we're not asking for a technical explanation here, but I think the key thing for us is, I suppose there's two things. One is that to treat the information as a shall I say, a corporate resource. That doesn't sound quite right. I've always looked at it as the patient record, from a clinical point of view, and we need this data to look after the patient, and then the data becomes a resource in the old days, we didn't have the AI concept. We had things like research and clinical audit, that sort of stuff. But it turns out it's the same data. If you structure it properly at a granular level, and you standardize it so you can actually pool it across patients, across hospitals. So for us, a lot of it's about standardizing how we architect and represent the data so that you can bring it together into one common pool and compute on it. So in fact, most of the efforts are at that level. And then, of course, when you have standardized data, you have to say, how do your systems work with that standardized data so that you're not creating artificial difficulties for all the various users who need to use it quite slightly differently. So there's a lot of challenges in that aspect of it. But I think that for us, I think a big part of it was demonstrating the value of the data, and then people were much more willing to work within the constraints of a highly standardized structured system.
And just another question from one of the attendees was around data warehousing and data storage. Are you using storage, or is this on-premise storage within the health authority, for example, AWS cloud or anything like that?
Yeah, we're very mindful of our duty, I shall say, to protect patient data. So we have not put any patient data in the cloud. We are looking at cloud for various other sorts of tasks, but we're essentially building an on-premise cloud. So we're taking the cloud technology and putting it inside and running it ourselves. We're big enough to warrant an actual that infrastructure, and we see a lot of benefits there. But we didn't start with that. That's rather new. But no, we're not taking. We're very careful with our data going off-prem. Very careful.
And I suppose during this pandemic, we've seen a huge amount of new data coming in, not just in terms of patients who are attending, but also those who are out in the community. We're obviously starting contact tracing and gathering data, possibly using medical devices. Have you integrated some of those new technologies from personal health as well?
Actually, we're looking very closely at doing, got some trials going. We haven't, so this is all stuff that we had planned, and it was on the horizon, but then, COVID hit. So it's sort of accelerated a lot of that work, excuse me. Now, what we have done though, it's actually happened more in the EHR sharing system. That's the one that we actually built for the government to, as I mentioned, link together all the various healthcare providers in Hong Kong. And so we actually have some projects specifically there about collecting things like, remote monitoring data from patients in a community setting. So we're doing some of that. Now, we're still within the hospital authority itself. It's more things like, nurses collecting the data. And so we're being more traditional there with those devices, but we're certainly looking at that aspect of a lot more, and that's something we'll be doing very soon, I should think.
Excellent. Now we're going to just break very briefly to do a poll, which I believe is going to come up on the screen. We've got a lot of attendees here, huge number of people, and we'd love you to just put into the poll as we talk here, what are the top 3 changes that you feel will change in the next 12 months? Thinking about your own environments out there, the people you're working with in your hospitals, the different authorities you're working with. What are the top 3 changes that you feel will change in the next 12 months? We'll give you a few seconds to drop information in. I'll get confirmation from my colleagues that information is actually dropping in.
I'm not allowed to vote, Tim.
Oh, yes, we're not allowed to vote, are we? I was hoping to be able to vote as well. It takes away our fun.
Absolutely.
Yeah. So I'm gonna just ask you a question, which is really quite close to our hearts, obviously, which is around contact tracing during COVID-19. A question's come up on the chat by Janice Shan. It says, why was Hong Kong able to do successful contact tracing during COVID-19 and not in other wealthy countries? And this is obviously something we're starting here in the UK only just now, and is perhaps something which has been slow to start. Other countries perhaps are thinking about putting this in place. Hong Kong, how does it achieve success?
Well, I can't really speak to why how other people have done, other countries have done. But in Hong Kong, certainly, I think, I really think a lot of it was our previous experience in SARS, because it was demonstrated then that contact tracing was a key aspect of defeating SARS. And actually, one of the technical solutions we did develop during the SARS was exactly around contact tracing, and having like net graphs of contacts and all that sort of stuff as part of a public health response. And so that's just something that we're already all geared up to do. I think the other one, of course, is that we weren't overwhelmed. We had we managed to put a lid on the numbers so that you could effectively contact trace. Because it is a laborious laborious process. And if you have too many cases, it's probably, frankly, impossible to do. So I think we're lucky in that sense.
So we have the numbers in.
Well,
so interesting.
That's what I would have said.
Yeah, adoption of remote care delivery model, i.e. telehealth, virtual consultation, 82% in that area. Acceleration adoption of data technology, again high. Staff education, that's a key question as well. And in fact, one of the areas, in terms of how do your staff know what is good information, what is new information. We know that the COVID crisis has actually generated huge amounts of misinformation. And how do you really ensure that a group of nurses and doctors know where they're getting their information from, and which is the right stuff, credible information?
Well, that is a very difficult question. I mean, it is a battle that we've been fighting for a while. The battle against misinformation. I would say that we spend a lot of, now that's not really exactly my area so much, but we do work on that, and it's having, I suppose, a consistent message. I think is one key thing. So we do spend a lot of time crafting the message, making sure it's consistent, and I mean, all I can say is you try and get it out in a very neutral tone. You have to have good science behind what you're saying. So you always have to have the science back you up. So I think those are some of the key things. The other one, I suppose, is nowadays a lot of it's about finding the influencers, sorry, the people who people respond to and trust, and get them to be the messengers, as it were. More. So building up a cadre of those sorts of people as well, I think is very important now.
Thank you. We've got another question here. I'm going to destroy the name. Sorry, Chi Wang, who's asking, how do you overcome the challenges you face in getting the public and private healthcare provider to contribute to a single EHR? How do you break down territorial behavior? Obviously, 30 years is a long time to achieve that, but do you have recommendation?
Well, I'm still not going to say we've achieved it totally. I mean, in the public sector, we pretty much have done that. There's no silos of information in the public sector anymore. It's become essentially one record across all sites. But in the private sector, it's not as easy. Now, what we did actually, and this started at least 15 years ago, we unilaterally let the private sector access patient records from our own system without any expectation of reciprocity, because we had it there and it would help patients if they were to seek different carers. So we've sort of been trying to get them accustomed to the concept of looking at data digitally, because to be honest, a lot of them left into private practice before they'd ever used a computer. So there's a long education process there. Now, even today now, where the uptake of the new system, the EHR system, is pretty good for them to read the public sector data. The private sector data is the contribution is less, it's less complete. One of the things, having structured schemes where you actually have models of care which are structured between public and private, and where the patients go back and forth. Usually there's also a financial component to that one, sort of like outsourcing the care from public to private and paying them for it. Then you have an information sharing component that's attached to that service. So then you're paying them, and so they'll do it then. So I mean, I think that's been an experience of a lot of places where it sometimes does need a financial incentive. Yeah.
One of the areas, and this has come up in the poll, it's come up in some of the questions here as well, is around privacy. Managing data security, as you say, you're fiercely protective of the privacy of patients, yet with track and trace, with an increased government oversight in terms of the people traveling through the airports, traveling through the countries and things. Do you see a move to decentralize some of this work, putting this out to the private sector? Do you see a greater reduction in the privacy needs as well?
I would actually say that we are increasing our focus on privacy. I mean, we're living in difficult times for many reasons, and people are very aware of there's a privacy problem. So we are very, very firm on protecting privacy of patients, and we're constantly enhancing our controls in that regard. So I mean, what we're also doing at the same time is giving the patients the control themselves if they want to share it out, and having mechanisms where they can give consent to various types of sharing, and to have them actually explicitly do that, rather than us just opening it up. I would say we're not. I mean, that was the last question, wasn't it, about opening up, relaxing privacy? We're actually going the other way.
The other way.
But doing it in a technologically sound way.
Yeah. And Joe again asks, what strategies have you used or planning to do for greater adoption of the HA Go, as those people in need or be fearful of technology, or reluctant to change their practice?
Sure. Yeah. Well, so I said we focus very much on workflow. So I'll give you an example of what we're doing right now with the telecare initiative. So of course you could do telecare by just doing what we're doing now, right, and just have patient and you chat. But what we're doing is that we're embedding the tele conference technology into HA Go itself, so that a clinician, when he schedules a patient for a tele visit, right, there's a whole. So today when you see for instance, an outpatient visit, there's a whole workflow around how the patient gets from the front door to register, to get to the doctor's office, right? That it's all been established. Now we're doing a similar thing with the tele, where the patient, they know they have an appointment, but then they go into a tele waiting room where a nurse just preps them for it, make sure everything's fine. Then the doctor, he's seen his last patient, he just goes, I'm ready for the next patient, and then the patient just goes into his room. So instantly, there's no fuss, the doctor's doing his televisit, and at the same time, of course, we have the CMS open at the same time for that patient. So the doctor does his documentation just as with a real encounter. And then, if the doctor needs to prescribe something like a tele information or whatever, again, it's just a thing from the CMS again. So we're trying to integrate the experience of telemedicine to the clinical workflow. Now for the patient side, it's even better, where they just have it appears in their HA Go that they have a televisit for such and such a time, right? And when it gets near the time, they click and say, oh, I'm going into the waiting room now. And then, like I said, then the nurse will connect with them, and then they'll set them up properly for the visit. So for them, it's just totally seamless. They just click a link on HA Go. So the idea there is that the HA Go for the patient will give them what they need when they need it. And that, we think, is the thing that we will hopefully drive that adoption. For the doctors, again, for them, it's very seamless. It helps them achieve the health delivery goals that they want to do, which is to see the patients virtually, and so make it easy for them as well. So it's very much about making it a seamless, helpful experience rather than something they have to work out.
Thank you very much, Dr. Cheung. I am really sorry we've run out of time in terms of the overall schedule today. We've got questions still on the question and answer panel. I'm afraid we haven't been able to get to those. We will try and pick some of those questions up as we go forward in this series. Just to remind you that we do have another one in this series next week. We're going to be following around the world conversations with other clinicians and see how they have also been impacted in their healthcare delivery as well. I want to thank everybody for attending. Apologies for the slight glitch on the PowerPoint presentation earlier. But please join us to meet with Dr. Benjamin Shi from Malaysia, 5 p.m. Singapore time on that call. Thank you very much, everybody. Thank you, Dr. Cheung. And we'll speak to you next.
It's been an absolute pleasure.
Real pleasure. Thank you.
Thank you.